Hi, my name's Karen Jennings, and I am a physical therapist at Methodist Hospital. And I am in my 6th year practicing, and I used to teach the kinesiology course here. I taught here for 4 years, and so unfortunately I didn't get to teach any of you here today. But what I'm going to talk to you about is my profession as a physical therapist. And I went to University of Nebraska-Lincoln for my undergrad, and I was an exercise physiology major, and then I got my master's in physical therapy at University of Nebraska Medical Center. Now, physical therapy school is a doctoral program, and they call it a DPT, which is a doctoral physical therapy. So, in this handout, which I gave you, it's kind of the boring stuff, but it would be good for you to kind of go through as an overview to learn what physical therapy is on the kind of long and lengthy, drawn out definitions of what we do as physical therapists. But I thought you needed to have this information. And then if you turn to page number 5, where it talks about the physician's role and the physical therapist's role, it's really important to know that as physical therapists, we are what we call a direct access state here in Nebraska. Now, I'm licensed in Iowa and Nebraska, and both Iowa and Nebraska are direct access states. And what that means is that if you come off the street and come in to see us for physical therapy, you do not have to have a physician's referral. If you want it to be paid for by your insurance company that you have, then you must have a physician's referral. And that's why they have the physician's role in physical therapy. And in the clinic that I work with in the Methodist Health System, we also have massage therapists in our physical therapy clinics. So we have 3 massage therapists, and actually I think one of them that used to be with us is Diana Bain. Have you guys had her for myofascial release? She was one of the gals that was in our office. We have a couple other massage therapists that actually work with us, and they assist us with things in our clinic when they're not doing massage as well as like technicians. And but if you look at this long definition, we just kind of brush through it because I feel like I should on this page number 5. Physical therapy means the examination, treatment, and instruction of human beings to detect, assess, prevent, correct, alleviate, and limit physical disability. Okay, and what I'm going to do today, you can go on and read through all of this, but I am going to take one of you guys through a physical therapy evaluation, and then what I would do as a treatment. How many of you guys here have ever been to a physical therapist? So quite a few have, okay? And I'm here to tell you that every physical therapist practices differently. So it's important. Some of you guys probably had really good experiences. Some of you guys might not have had as good as experiences. And it kind of just depends. Like, I am a manual physical therapist, so I do a lot of massage and myofascial work incorporated in what I do in physical therapy. But I have people in my office that don't do manual work. They just evaluate and give people exercises. So, or they use other modalities like electrical stimulation or ultrasound or things like that. But I think that's why I always enjoyed teaching here as well when I was at the Universal College of Healing Arts, is because I am such a believer in the manual work that needs to be done. Okay, if you go to the next page that I kind of wanted to touch upon, this is the branches of medicine that physical therapists cooperate with. You guys all have this? Okay. Cardiology, our physical therapist role is not as prolific in cardiology anymore because that is held more with there's cardiac teams, and that's more with exercise physiologists. But it depends on the hospital. With Methodist Hospital, The PTs are not in cardiac rehab. Those are exercise physiologists. Dermatology, we do a little bit with that. It's more with the wound care. You guys know what a wound looks like a decubitus ulcer or you guys know what I'm talking about? Okay. We do whirlpool treatments and debridement of wound care. And gerontology, we have several people in our clinic that have masters in gerontology, and we have a geriatric clinic that we work with specific physicians at Methodist Hospital that we do exercise programs for geriatrics. Internal medicine, just a lot of internal medicine docs refer people to physical therapy for whatever their needs may be. Neurology, neurological disorders like traumatic brain injuries, strokes, balance disorders. We have a balance clinic at Methodist. We have 3 physical therapists that deal with balance, and it's a really comprehensive program that's just excellent. We use a lot of things, like we use the ball, and they have specific tests that we use on them to improve their balance, because one of the biggest problems with the geriatric population is prevention of falls. And as your grandparents or relatives get older, that's a big concern, is if they fall, because what happens when they fall? They break their hip, or something else bad usually occurs, hit their head or whatever. So also with neurology is traumatic brain injuries. You guys familiar with what a TBI is? Traumatic brain injury. If you hit your head in your skull, it causes a swelling of the brain, which can cause a lot of neurological things to happen, similar to a stroke. So not only is your physical impaired, but your speech and your personality. You have a lot of personality disorders. A lot of people say you'll never be the same person like you were before. Well, we have teams at the hospital where speech works with occupational therapy, works with physical therapy. Do you guys know the difference between occupational and physical therapy? Does anyone here, are you able to tell what the difference between physical and occupational therapy is?
Occupational.
It's close. Physical therapists work with physical impairments. Occupational therapists work with impairments that deal with activities of daily living. Getting your socks on, cooking, cleaning. It's very functionally based type of therapy. So where we come in to, like, for example, you have someone in the hospital that the doctor has a referral for physical therapy and to say, evaluation to treat for the physical therapy for leg strengthening and occupational therapy for upper extremity functional activities. So what we do, we come in and we do walking, we do balance training, we do leg strengthening, we do transfers, and then the OT will come in and she'll work with them on brushing their teeth by themselves, by getting on and off the toilet, by dressing themselves, cooking. They have kitchens, different things like that. So that's all occupational therapy. Also, occupational therapy, we usually say from the elbow down, occupational therapists do work with, so the more fine motor skills. And PTs work with more the large muscle masses. So, okay. Oncology, that's just pretty much weakness. And every 6 weeks I am an outpatient physical therapist, or an ambulatory care, which means they have to be able to drive and walk into the hospital to see me. That's considered outpatient. Obviously, inpatient physical therapy are when they're in the hospital. So, but once every 6 weeks, I have to work on the floors. And it's always a good experience for me to get up there and work on the floors and tone down what your treatments are in a lot of ways. But okay, orthopedics. This is my specialty. I'm an orthopedic. We call this outpatient orthopedics. Strains, sprains, fractures, dislocations, subluxations, arthritis. You guys know the difference between a sprain and a strain, right? You guys learned that in your kinesiology class? Okay, good. Basically, I treat athletes, sport injuries, or probably my biggest population is 40-year-old back pain. You know what they always say about what you do in your 20s, you pay for in your 40s. So be careful, you young people. I do a lot of shoulder, rotator cuff. You guys have heard of rotator cuff injuries, ACLs, ankle sprains, motor vehicle accidents, which is a lot of whiplash and low back and things like that. So that is what orthopedics is. Okay, pediatrics. Now that's a whole nother division of physical therapy. They are like on the children's side, or they work with kids that come in and work with that have cerebral palsy or muscular dystrophy. A lot of the pediatric physical therapists, they go into the schools and they work with the children. And you guys have seen those when you guys were back in high school and junior high and elementary school. They would come in, work with those people. Physical medicine, physiatrists. We have, in our department, we have 2 physiatrists. And you know what a physiatrist is? A physiatrist is a rehabilitation physician. Okay, there's a great physiatry school in Kansas City. And these people, the internal med docs, when someone is acutely injured, like they have a stroke, they come into the hospital, internal medical station, sees them for a little bit just to stabilize their symptoms, then the physiatrists take over. And the physiatrist is in charge of their long-term care if they have a stroke or a traumatic brain injury or something like that happens, or even into chronic back pain. Anything that's chronic, the physiatrist will take over their long-term care. And there's excellent, if you look in the yellow pages, you'll see how many physiatrists there are in Omaha that we're all pretty, just sitting here, we're all pretty healthy people. So we haven't had to go down that road where you'd have to work with a physiatrist. But if you had someone in your family that has had a stroke or something, then you will have to eventually do that. Okay, pulmonary, that is pretty much, we are instructed in that in physical therapy school to do like tapotement and to get the lungs moving. A lot of, tapping on the lungs and trying to get those to open up and the airways to improve. But really, that is respiratory therapy, does all the pulmonary now. So that's out of our scope of practice. Surgery, post-surgical patients, we do see a lot of them, post-back surgeries, knee surgeries, you name it. We have also in physical therapy, we have a women's health sector, which does all pelvic pain, postmenopausal. They do incontinence. Urinary incontinence is a huge area of physical therapy rehabilitation today. Fecal incontinence. So for you ladies that have had children, that stress incontinence. So we have 6 physical therapists that I work with that just deal with women's health and post mastectomy, which is there's 2 lymphedema specialists that just do with post mastectomy. So I know that lymphedema massage is becoming much more prevalent. For you guys can take courses in lymphedema massage. What's the difference between you guys and us? Well, the people that we have in our clinic are certified. They went through the month training that goes through it and have to pass the test. And then the doctors are referring them, so that obviously they get paid, but for you guys are the long-term care of the lymphedema for, the years after they've had that. So it's definitely a good area for you guys to get involved in because it'll be used more and more. Okay, rheumatology. What do you guys know the difference between rheumatoid arthritis and osteoarthritis? RA versus OA. Rheumatoid is due to a rheumatoid factor, and that's an autoimmune disorder. It's very common. It's not very common, but it's fairly common. But it's joint pains, and it's on both joints. Like on osteoarthritis, if you have people say they have a bum knee. Oh, I got arthritis in this one knee, and I get up in the morning, and as soon as I walk around for a little bit, it's okay. And then it gets worse as the day goes on. Rheumatoid arthritis usually occurs in both knees, elbows, wrists, hands, but it's symmetrical on both sides of the body, and it's definitely a morning stiffness, but it takes longer than the first 5-10 minutes to be walking around to get rid of the stiffness. It usually takes 20 to 30 minutes, and these people that deal with rheumatoid arthritis have chronic inflammation in all their joints. And so if you have someone come in and they want a massage and they say they have rheumatoid arthritis, then you also need to be fairly conservative on their joints too, because they have little nodules, little fatty deposits in all of their joints, so their joints are going to appear larger. And heat is not a good thing for rheumatoid arthritis, because that will increase the inflammation of those areas. So just be rather conservative around that and find out if they do say they have rheumatoid arthritis. So, okay, but the circulation and the, like the lymph massage stuff would be good for them. Okay, so that gives you kind of an overview. There's so many entities in physical therapy that you don't even think about. We work in hospitals. We have people own their own business, nursing homes, schools. There's a lot of different areas or avenues of physical therapy. Do you guys have any questions thus far? Okay. All right, so now that we got through the boring part of this talk, what I'm going to do is I'm going to take you guys through an evaluation. So does anyone have anything going on? Like, do they have a bad shoulder or a bad knee or have anything going on? What do you have? Bad shoulder? Okay, Julie, come on up here. Okay, I'm going to take you through what a normal physical therapy evaluation would be like and what I would do for this patient. Okay, so Julie comes in. That's fine. Oh, was it going to tip over? Thank you. She's saving my legs. Okay, so Julie comes in, and she was referred by Dr. Cook at Methodist because her shoulder has been bothering her. What's that? Is your doctor Dr. Cook? It's fate. Okay. So Julie comes in and she says that she has a script from the doctor that says evaluation and treat. And so I bring Julie in, and first of all, I sit down and I chat with her. Have you guys ever heard what a SOAP note is? Okay, what does SOAP note mean? Correct. Subjective, objective, assessment, plan. Okay? That's what SOAP note means. So what we would do is, I'm going to do the subjective first, right? So what does subjective mean? What she's going to tell me, right? Okay, so tell me about your shoulder. What happened to your shoulder, and how can I help you today?
I was in an accident. A porch collapsed on me, and I hit my elbow, which it strained everything up into my neck and then my shoulder.
Okay, and when did this happen?
It happened 2.5 years ago.
Happened 2.5 years ago, and it's still bothering you. Has it gotten any better?
Oh yeah.
What % better has it gotten since then?
Oh, it only aggravates me every once in a while.
When does it aggravate you?
When I've done like a lot of massages.
Okay.
Put a lot of strain on it, raking. Just put a lot of strain on it. You know, take it easy.
Where does it hurt when it does? You said up into here? Up in here. So what muscle is this for you guys that are taking kines? Upper trapezius? Okay. And how about in the front of the shoulder? Nothing in the front. So it's just a
levator scapula and my
okay.
rhomboids.
So back in here. Okay, and I can feel right now that she's having some winging in her scapula. So, okay. So what I would do, and do you have a T-shirt or something underneath that?
Yeah, a sports bra.
Yeah. Do you mind showing us? Okay. That's great. Perfect. Okay. So, and what are your goals of physical therapy?
To be able to turn my head to the left without having pain right here.
Okay. And what is your pain like on a scale of 0 to 10?
Today I have a vertebrae up here, so it's probably like 10 being high.
Uh-huh.
Probably like an 8.
An 8. Okay, so that's pretty high.
But I've built it up over the years, like a tolerance kind of.
Okay, 0 is no pain and 10 is the worst pain you've ever felt, and it's still an 8.
Yeah, maybe a 6 or 7 then.
Okay.
Yeah.
Okay, because 10 is like you're dying in the hospital, so.
Oh, okay, no.
All right, so she's about a 6 or 7, which really is pretty strong, actually, to have to continue to do that and to have it been 2 years ago to have to continue to battle that. So she really needs to nip this. Okay, now, anything else that you want to tell me about this? Do you have headaches?
Yeah, that's I started getting really bad headaches that would shoot up into my head,
Mhm.
and my rib pops out up here
Okay.
from the winging, I guess, of my
Uh-huh,
scapula. You can feel it. It's up today.
Okay. Okay. So she might have a little bit of costochondritis going in through here. Okay. All right. So that's the subjective part. Next thing I'm going to ever do is that we do the objective part, which is what I see. Okay. And first of all, what we always start with pretty much all the time is posture.
Which I have to work on.
Okay. And then I'm going to have her turn this way. Okay. And then let's turn towards you guys. Now, what do you guys see in here? Do you guys see one shoulder higher than the other? Okay. I'm going to step over here. Okay. Do you see any difference in muscle tension? Do you see, like, this one seems like it's contracted, and that's why it's pulling this up. So there's definitely much more muscular tension in this side than there is in this side. Okay. How about her head? Does her head look okay? Does it look normal, or is it pushed to one side more than the other? Let's take a look. Yeah, it does look a little tilted. So she is showing a little bit of. Okay, so I would just, and then I always look from the side view, because if you do a plumb line, her ear and her shoulder should be in line. She's not bad. I mean, she's got a little bit of forward shoulder, but really she has pretty good posture. She said that she's been working on that. So I think that makes a difference. And she looks, it's not bad. Okay, now, next thing we're going to do is I'm going to have her turn towards me. Then I want you to take your arms out to your side like that. Hold, don't let push down. We're just going to do a general muscle test. So we did shoulder abduction, shoulder flexion. Okay. Okay, turn supraspinatus. You guys know your rotator cuff muscles. Okay, arms down. Okay, out to the side. We're going to test external rotators. What are your external rotators? You guys remember those? Infraspinatus and teres minor. Good. Okay, hold in. Don't let me pull out. Hold in. Okay, good. Okay, and we'll do extension. Notice what I'm doing. Am I doing both sides? Because I'm looking for symmetry. Okay, that's fine. Now, her rotator cuff seems good. Does that bother you at all? Mm-mm. Good. Okay. All right, let's go ahead and have you lie down. We'll put your head down here on your back. Okay. Now, I'm going to do some flexibility tests. You should always do the uninvolved or the, quote, good arm first, just to see. She's got a lot of flexibility, almost too much, which is probably what the problem is. She could be a pitcher with this arm. Were you a swimmer?
I was a pitcher.
You're a pitcher?
Yeah.
Hey! All right. I'm getting lucky.
You are.
Okay, scoot over a little bit more towards me. I'm testing her flexibility. This is not normal for most people. I mean, most people don't have this much flexibility.
Too much yoga?
What's that?
Too much yoga?
She asked me if she's had too much yoga. Does that bother you? A little bit.
Not bad at all.
Okay. I don't know if it's I wouldn't say it's too much yoga, but I would not stretch to the end ranges.
Okay.
Because you're causing, the shoulder is like a golf ball on a golf tee, right? So you got all these muscles. Well, hers, because of her flexibility, is so much that it can cause the shoulder to anteriorly come forward too far and come out of the cup a little bit, and that's what causes. So it's a little bit of instability in there. Okay, I think her weakness is not in the rotator cuff. I'm guessing that her weakness is in her rhomboids, middle trapezius, lower trapezius area, which is the scapula, the stabilization of the scapula, which is very important to the balance of the shoulder. We're going to test that next. Go ahead and go on your stomach. Okay. All right, I'm going to take this arm right here. Okay, actually, I'm going to have you just come over here a little bit closer to me. There you go. And I want you to turn the other direction so you're not facing me. There you go. Okay, this is going to be a test for a middle trapezius. Okay, hold that position right there. Thumb up. Hold, don't let me push down. Okay, that's the first one that she's weak. Do you see how weak she is? She doesn't have any strength back in here. Okay, then we're going to test rhomboids. Thumb up right there. Hold that position right there. Don't let me push down. Weak. Okay, she's real weak through there. Okay, now we're going to test for a lower trapezius. Hold that position right there. Don't let me push down. Okay, she just breaks. Do you see how she just breaks her scapula just broke there? That's on that side. Let's go ahead and test the other side. Okay, let's kind of scoot over towards here. Same 3 tests. Okay, let's do the middle trapezius first. Hold that position right there. Don't let me push down. She's even weaker on this side. Okay, let's do rhomboids. Let's do rhomboids next. Hold that position right there. Don't let me push down. Yeah, okay, same thing. She's pretty symmetrical, but she is a little bit weaker on the left, which is normal because she's probably right-handed. Hold, don't let me push down. Okay, there's no hold there. No. So, okay, go ahead and sit up. Okay, then we're just gonna, what I would do is take a look at, just do the palpation part of it, and I try to do it symmetrically so feel, and there's definitely more tension here through this left-hand side. A lot more. Does that hurt? Feel good? Yeah. Okay. And what she's pointing to is the upper trap is probably substituting and is getting inflamed because it's trying to help as a stabilizer to her shoulder. So, okay, how about down in here? Is that sore at all? Mm-hmm. No? That sore there? A little tender there? Mm-hmm. How about in the back of the rotator cuff? Mm-hmm. No? Okay, right down. Relax. Oh. How about in the front? Mm-hmm. So, all that I would say for her is, if she was my patient, is I would do some myofascial work and massage to this upper trapezius here, because this is definitely kind of causing her problems, and that's probably what's causing her the headaches. The reason, but the root of the problem is not this thing here. The root of the problem is that she is weak in her back muscles. So I'd have her do a lot of rowing, middle rows type of work. I'd have her do lat pull downs. I'd have her lie on her stomach and I'll have her do a couple exercises that I'd have her start on right away. Go on your stomach. Is put both your arms out to the side, and then I want you to bring them up together and then down. Okay? And I'd have her relax your head when you do it. There you go. There you go, perfect. And just have her work primarily on her rhomboids and middle trapezius. Okay? And I'd have her try to do 2 sets of 10. And then I'd have her do this exercise here. Actually, come up a little bit. You can go ahead and put your head, have your arms at the outsides, legs hanging down, okay? Then lift up together, okay, and down. Lift up, okay, and that works lower trapezius. You can really feel it fire, as well as a little bit the erector spinae. And that would really work these muscles right here. A lot of people are weak through here. Because you know what? What do we do when we go to the gym? Work those deltoids, work those biceps. We want to work the muscles that actually show, right? And we forget about working the back muscles. And the back muscles are just as important as the front muscles. Okay, that's fine. Okay, so then I would put her on exercises to do that. I'd have her do the arm bike just to work on some general strengthening, but I would just do specific, as many scapular exercises as I could come up with for her, and then working on this right here. So maybe, get a massage in that area.
I had myofascia for about a year.
Mm-hmm.
Through the
Good.
physical therapy.
Did it help when you did that?
Uh-huh.
Yeah,
and then
good.
we had the exercises, but I actually went through something else with massage that got rid of it.
Good.
Yeah, it just comes back and keeps flaring back up.
Did you stick with your exercises too?
No.
And see, that's a lot of it, is just the compliance part of it. When I set my goals, when I do my evaluation of my treatments, one of my number one goal is patient will become independent and compliant with all home exercise program. Because that's really what it's all about. I mean, you think about anything you do in life, your diet, your exercises, your study habits. It's all about being compliant with what you're doing. Okay, we all have our weaknesses, so, but, all right. Okay, good, good. All right, any questions with this at all? Guys, is this kind of what you guys thought physical therapists do?